Hello, and welcome to Breast Cancer Conversations, a podcast brought to you by survivingbreastcancer.org. I'm Laura Carfing, breast cancer survivor and founder of survivingbreastcancer.org, a nonprofit organization providing community, education, and resources to empower those diagnosed with breast cancer and their caregivers from day one and beyond. Hello, my friends. I am so excited to be kicking off another week with all of you. If you are an avid listener tuning in week after week, welcome back. I am so glad you're here. If you just discovered Breast Cancer Conversations and this might be your first time or first 5 times listening, welcome. I'm so glad you have found us, and we are here to support you and answer your questions and really provide that level of support and community through our podcast. I would also like to acknowledge and give a huge shout out and so much love to the sponsors making our podcast possible, our friends at GE Healthcare. Thank you, as always, for supporting the work that we do at survivingbreastcancer.org and on the podcast Breast Cancer Conversations. I am so excited to let you know about today's podcast with Dr. Jacene and Dr. Specht. Dr. Heather Jacene is the Assistant Chief of Nuclear Medicine at Brigham and Women's Hospital, Clinical Director of Nuclear Medicine at Dana-Farber Cancer Institute, and an Associate Professor of Radiology at Harvard Medical School. Dr. Jacene has served as a Director on the American Board of Nuclear Medicine and on numerous Society of Nuclear Medicine and Molecular Imaging committees. Her current position includes Scientific Program Chair and the Value Initiative Quality Domain Chair. Dr. Jacene's research focuses on using radiotracers to characterize tumors and monitoring cancer response to therapy. I am pleased that we are also joined by Dr. Jennifer Specht. Dr. Specht holds the Jill D. Bennett Endowed Professorship in Breast Cancer and is a board-certified medical oncologist who specializes in caring for patients with all stages of breast cancer. Her expertise includes treating women with triple-negative breast cancer, which is an aggressive form of the disease that does not respond to hormonal medications. At the Fred Hutch Cancer Center, Dr. Specht sees patients in the Bezo Family Immunotherapy Clinic and leads the Phase 1 breast cancer program. Dr. Specht is also a clinical trialist and the clinical research director of the Breast Oncology Division. Her research interests include immunotherapies, novel therapeutics, and the use of molecular imaging to better understand the biology of breast cancer. It is a pleasure to have both Dr. Specht and Dr. Jacene here with us today.
At the end of the day, our big goal for the feature trial is that by using FDG PET and showing that the changes in the glucose uptake are meaningful, meaning that it tells how well the treatment's working, that we'll have a new criteria so that patients can, when they start a treatment, they can get an FDG PET, 3 months later they get another one, and we can be really confident about that their treatment is either working or it's not. Because right now we're kind of making guesses as clinicians and as doctors and patients because we don't have a good measure, a good response measure. And so we're super excited about the potential that FDG PET may hold, not only for day-to-day clinical practice, but also to give a new set of criteria like we have for CT scans that would allow patients with bone disease, bone-only metastatic disease, to get into really exciting new drugs and to be able to participate in research studies.
Welcome to the conversation. And I love, too, that we have different perspectives, right? And really bridging that gap of how our medical colleagues across different divisions are being able to work together to treat the patient collectively and holistically, which I think is so important. Dr. Jacene, you mentioned something that I think is just a great place for us to start when we think about nuclear medicine. So as the layman person who was diagnosed and they tell me to go, to floor 4 over in this wing of the hospital and you see nuclear medicine and I'm like, oh my gosh, I was really excited. I don't know if they still do this. This is going a couple of years back. Getting a card to say that I couldn't go and fly on the airplane and go through the metal detectors because I was radioactive for 72 hours. And I was like, that is the coolest thing. I'm like literally glowing right now and I'm radioactive. So that's my experience with, nuclear medicine. I love that you kind of in your introduction shared it as an imaging modality. Can you tell me a little bit more when we think about nuclear medicine? What is it and what does that actually mean?
So I'm glad you asked that question. I'm also glad you went to the fourth floor and not the basement, because oftentimes nuclear medicine will be in the basement. But nuclear medicine is really a branch of medicine that uses radioactive materials in the body 2 different ways. I would say the first way is that we give very small amounts of radioactivity, and they go to look at different processes or how bodies and the organs and the tissues are functioning. The radioactive material lets us take pictures with special cameras, and that is diagnostic nuclear medicine, where we're taking pictures and radiology. And I'll just contrast that a little bit with radiology, or what people typically think of, is where that looks at structure, the anatomy of the body and the tissues, and nuclear medicine is really looking at how the body, the tissues, the organs, they function. There's a second component of nuclear medicine, which is also therapeutic. So we could give larger amounts of radioactivity to help treat some cancers in a very targeted fashion. So that's really how I would generally describe nuclear medicine. Whether you get a diagnostic test or a therapeutic test, you're going to get the little card. But there's some different instructions that we give depending on what test or what therapy that you're actually getting.
When I went for my mammogram, I was seeing a radiologist, but that was different than when I was getting radiation therapy as well. And now we have this new dimension of like the nuclear medicine and how that's being integrated into this umbrella of radiation and imaging. So very important to break it down at that level. Thank you. And so following up on that too, Dr. Specht, if I can ask you, because I know from the oncology side, you're looking at the biology of the tumor, right? And you're kind of taking a sense of, what are the characteristics of it? How do I make these treatment decisions for my patients, et cetera? Tell me a little bit more about the biology of a cancer cell, and then when you would start integrating and I guess ordering the diagnostics or other workups working with nuclear medicine.
Yeah, so we're privileged to have a lot of different tools to help us understand, number one, to detect cancer, to find it in the first time, as well then to try to evaluate when we know that there's a diagnosis of breast cancer, to try to understand how well particular treatments are working against the cancer. And so we utilize different tools that Dr. Jacene and her colleagues have. So that can be everything from a mammogram, which is in my non-radiology terms, is a very fancy X-ray to look at differences in density to help us identify a mass in the breast. And that's a diagnostic test. And then what Dr. Jacene and I get the privilege of working together on is more about looking at the biology of a breast cancer cell. And so there's a lot that goes into that, but we know that there are different types of breast cancer that we think about with regard to hormone receptor status, so estrogen, progesterone receptor, and HER2 as well, to help us kind of define what type of breast cancer and what types of treatments. Some of those markers, we're actually getting to the point where we can actually measure those markers, not only just that the cancer is present or not, but whether or not those markers like the estrogen receptor are present. And that's a special type of nuclear medicine imaging called FES imaging that I think that you had Dr. Dedeshi talk about. But again, there's a lot of different types of tools. And so for some of the interests that we have, it's looking at the tumor based on using glucose. So cancer cells generally grow more quickly sometimes than regular cells because they're trying to grow faster. And we can actually measure that glucose uptake in the tumor. And Dr. Jacene can explain this better than I. But when we do a standard type of image called an FDG PET scan, that allows us actually to see parts of the body and to see areas where the cancer may be using more glucose. And so it allows us not only to potentially detect that there might be cancer in another place in the body, but it also allows us to understand a little bit about the biology. So you can imagine that if the cancer is growing, there might be more glucose uptake, whereas if the cancer is not growing, hooray, or if it's dying, the cancer cells would use less glucose uptake. And we can actually measure that with the really sophisticated type of testing that Dr. Jacene does. And so as an oncologist and from our patient perspective, we all work together to kind of pick the right test to understand the question that we need to answer, what would be the best test to help us know what's going on for a patient and the cancer that they're dealing with.
Yeah, no, that's incredible. Thank you for explaining that. So just if I could re-say that back and you can tell me where I'm right or wrong, right? So if I'm hearing correctly, right, we have an FDG PET, which will let us know where the glucose uptake is happening to detect the cancer. But then the FES version of it will actually be able to measure the biology and whether or not there are estrogen receptors on those cells.
Essentially, yes, that's correct. And then, at different times, we can use the FDG to maybe assess if you start a new treatment, how well that treatment's working based on changes in the amount of glucose uptake that happened over the course of a patient's journey and the treatment that they're receiving. So again, we're focusing on using some techniques that are often used for patients who have more advanced breast cancer that has metastasized or spread. But again, some of these types of techniques could also be used for earlier stage patients as well. It really depends upon what the question and what the particular need is.
That's fantastic. And Dr. Jacene, how are you experiencing this research and the work of, these diagnostics and therapeutics in the clinical setting, right? When you see a patient come in, how is that experience? Are people really excited now that they're getting more information to be able to make these decisions?
I think the big answer is yes. I think that the nicest part, I think most recently, is that there's really been a lot more understanding and acceptance throughout the community about the different possible uses of nuclear medicine and what the different tests are used for. So there's a lot of collaboration that's going on to really figure out which test should I use when. Is this the right test or is this a different test that I should use? So I think generally yes, but it's also sometimes there's a little bit of pause because sometimes not everything that's cancer uses glucose. So sometimes there's a little bit of worry about my test may show cancer, but it might show something that's not cancer, and that might lead to a lot of different things, worry from the patient, other tests. And so I think that it's very exciting in that sense, but also we still have a lot to learn, and the collaborations are really the key I'm finding. And what's been most exciting for me is really working together with Dr. Specht and other medical oncologists to really hone in on what are the key clinical questions that we need to answer and how can nuclear medicine really help that. And to me, the collaboration has been the most fun part because you really draw on the expertise across both to be able to design the best clinical trial or answer the clinical question that's needed. And that is really rewarding, and I think will end up being most helpful for the patients.
Amazing. So I wasn't sure, Dr. Specht, if you had something to weigh in on. So, I think I should have maybe started with this question too, because you guys are collaborating. How did this collaboration develop? How did you guys meet? What were some of the research questions that you guys were trying to solve and look further into?
Maybe I can start, I guess, with that one and Heather can fill in. So one of the research interests that I've had for several years has been in collaboration with another really amazing nuclear medicine physician named David Mankoff, who used to be at the University of Washington and continues to be a great collaborator for both of us and a terrific friend. But one of the interests that our group at University of Washington has had for many years is specifically regarding patients who have breast cancer metastases that are really exclusively limited to the bone. And the bone is kind of the most common place for breast cancer to spread to. And there's a fairly large group of patients who really don't have disease anywhere else. So they have stage 4 disease, but it's limited to the bone or the bone marrow, meaning that they only have disease kind of in the bones, but nothing in the liver, the lungs, or other sites. And so we've been doing research, and I've been doing research with Dr. Mankoff for several years, trying to understand what might be the best imaging technique to be able to determine how well treatments are working for patients with what we call bone-only or bone-dominant metastatic breast cancer. And in that work, we were interested in potentially designing a clinical trial. We had done a small pilot study at the University of Washington that actually suggested that FDG PET scan that we mentioned, that might be a good way to know how well treatment is working for women and men who have breast cancer in the bones. And so we did a small study with just under 30 patients, and that gave us kind of pretty interesting results. And we saw that those results were similar to other groups, other single institutions who looked at this question. And Dr. Jacene also had a great deal of experience in using PET. And it was actually David Mankoff, I think, who initially introduced the two of us at a meeting and said, you have similar interests. This could be a great collaboration to try to design a larger trial that would be more definitive to really help understand how well FDG PET may be used to help this pretty large group of patients. And so that was how we met.
I love it.
And that was now several years back, and it took some time to develop the clinical trial, but we're really excited to see it continuing to accrue and develop, and obviously super excited to see the results and really grateful to the patients as well. And then along the way, Dr. Jacene has developed more trials, and it's just been a terrific collaboration to think about how we best use those nuclear medicine tests to really make a big impact in terms of how we can help patients on a day-to-day basis. And so that's really been the focus. And she's, doing additional studies for patients with HER2-positive disease. And I'm just, delighted each time we get together every 6 months or so to think about where we can work together more.
Oh, that's fantastic. I want to spend some time also digging into the clinical trial piece this upcoming weekend. So this is a very timely conversation. I'm heading to Philadelphia for the Living Beyond Breast Cancer Metastatic Conference. And so if there are opportunities for us to recruit patients to any of your ongoing trials, there might be, please let me know. I'm happy to help support and, share the information as well with the populations that we're all trying to serve. But before we jump into the clinical trial piece, because I think there's a lot to unpack there, a couple of questions that I wanted to just ask and get a further understanding more for you, Dr. Specht, as the oncologist. Why is bone mets in particular, is it more challenging, I guess, to understand what those lesions look like? Are you doing bone biopsies, or do we know that if it started off in a primary breast site and then metastasized later on, are we still treating it as if it were the first primary characteristic, et cetera? Can you help me understand a little bit about what happens? And I'm selfishly asking too, for anyone listening, is as someone with early stage, I am constantly worried about, metastasis and recurrence. And so I think it's just one of those things where oh gosh, what's going to happen and how do we know? So that's kind of where the question is.
Yeah, there's a ton to address there as well, and some things that I think we still don't know, despite a lot of very smart people looking into this. But we do know from many, many studies and from clinical experience that breast cancer specifically, breast and even sometimes prostate cancer, but we'll focus on breast cancer, seems to have an affinity and an attraction to the bone and the bone marrow. There's something fundamentally, there's an idea called the seed and soil hypothesis, this notion that breast cancer cells are sometimes drawn to that bone environment. And it's a place where, for some reason, they seem to feel comfortable setting up shop and growing. And so there's a ton of research trying to understand why that is and how we can interfere with it. So there's a lot to think about there, but the problem that Dr. Jacene and I are trying to sort of help solve is a little bit more simple. We know that the bone is such a common place for breast cancer to spread to. And we also know that a lot of different types of imaging, particularly the common types of imaging, such as CT or bone scan, which is another type of imaging test, those can be very helpful when we need to diagnose bone metastasis. So for example, if unfortunately a patient comes in that's had breast cancer that says, I've had this back pain, I didn't really remember an injury, it seems like it just keeps getting worse, I've tried ibuprofen, I just don't really know what's going on. And so for me, that's kind of a red flag to say, gosh, should we do some additional imaging? So we often start with things like a CT and a bone scan, which actually are quite sensitive to be able to tell us whether there's a problem in the bone that could be cancer. Now, in order to confirm that, you mentioned, and we do need to do a biopsy because we absolutely need to be totally certain before we commit to giving someone a diagnosis that's going to be life-changing, meaning a stage 4 diagnosis. And it's absolutely essential to do the biopsy because we have so many targeted therapies. We have to confirm, number one, that it's breast cancer. And number two, we need to get additional genomic information to understand if it's still estrogen receptor positive or what the subtype is, as well as some new genetic changes to understand if that patient may be a candidate for particular therapies. So I won't bore you with all those details, but the biopsy is absolutely critical in order to really help us make the right treatment decisions for a patient.
I really appreciate you taking that deep dive into like what that path looks like and to get us, to all the imaging modalities and how you make some of those choices. So Dr. Jacene, following up on that as well. So, we have these questions that we're trying to answer and trying to understand, what are the biological characteristics of the cancer cells? Is the treatment that my patient is on, is that working? How well is it working, et cetera? Can you tell me a little bit about the clinical trials that you're developing and a little bit more about that work you're doing in the research sphere?
Sure. So I'll follow up on what Dr. Specht already said. There's really two studies. The one that we're working on with Jen, which is called the FEATURE trial, and that is the one that's really built upon the work that she and Dr. Mankoff did, and that's looking specifically on how the bone metastases are responding to treatment. And that's really focused. We talked a little bit about CT scans and bone scans, which are very sensitive to look for the metastatic lesions. But sometimes those two scans, and this is a little bit technical because we have the different radio tracers, they image different things. And sometimes the CT scan and the bone scan, they can see the areas that there's tumor that's growing, but they can also show you areas where there's tumor that's healing and responding to treatment. So the FDG PET scan really looks at the active tumor, the tumor that's actively growing. And then when you look at it after you've treated it, you can see that hopefully the glucose is declining or it's not declining. So it gives a little bit of a more, I think, accurate picture of how the cancer is, whether it's active or not, or whether it's responding to the treatment. So that's really, to me, very exciting in that group of patients because sometimes the tumors, they may look very similar on bone scan and CT scans over time when you give different treatment. And we don't have a great tool for looking at the change. And we think that the FDG will give us that tool. So I think that's one of the studies that we're doing. I don't know, maybe, do you want to add anything to that, Jen, before I go to the other one?
Yeah, maybe if I can add just a little bit more.
Yeah.
So again, we kind of mentioned, these patients who have bone-only disease are really pretty common. And oftentimes, actually, they get left out of clinical trials because disease that's confined to the bone isn't what we call measurable, which is another technical term. But when you talk about clinical trials and about how new drugs are approved, they're generally approved because we can measure a decrease in the size of the tumor with a new treatment. And there's a way to do that using CT scans that works brilliantly for individuals who have cancer that's spread to the lung or the liver or the lymph nodes. But oftentimes, patients who have only disease in the bone, they actually haven't been able to participate in those really exciting new novel therapy trials because we haven't had a good way to know how well the treatment's working. So if a drug company develops a new great drug, they often only test it in people who have disease in the liver or lung where they can easily measure it. And so really, At the end of the day, our big goal for the feature trial is that by using FDG PET and showing that the changes in the glucose uptake are meaningful, meaning that it tells how well the treatment's working, that we'll have a new criteria so that patients can, when they start a treatment, they can get an FDG PET. 3 months later, they get another one, and we can be really confident about that their treatment is either working or it's not. Because right now, we're kind of making guesses as clinicians and as doctors and patients because we don't have a good measure, a good response measure. And so we're super excited about the potential that FDG PET may hold, not only for day-to-day clinical practice, but also to give a new set of criteria like we have for CT scans that would allow patients with bone disease, bone-only metastatic disease, to get into really exciting new drugs and to be able to participate in research studies. And again, I'm a clinical trialist. The research studies, this is my passion. This is how we move things forward, and it's how we make things better for all the patients that we care for. And so to be able to do a small thing that might let those women be involved in a clinical trial, to me, would be a huge gain. And so that's what we're super excited about.
100%. That is incredible. That gives me goosebumps as well. And I think one of the things that we're passionate about also at survivingbreastcancer.org, and we work very closely with our, NBC leadership team members and our board of directors, is to really let people know and educate people on the benefits of participating in a clinical trial and demystifying a lot of the fears or anxieties or concerns and letting people know you're getting so much, like, not just standard of care, but better than standard of care access to information, and people are looking after you. And it's really, yes, you might receive some benefit, but then also people who are so willing to engage in clinical trials because they know they're doing something for people behind them, coming along. So I love that. I think that's so important. I appreciate you sharing that.
Thanks. And we're super grateful to the patients. And so just to kind of finish, and I don't want to sound like an advertisement, but the feature trial is really designed. It's not actually, it's kind of a novel study, and it's a little bit different because it's not actually a treatment trial. So what we're testing the ability of the PET scan to help us predict outcomes, meaning to help us predict how well a treatment will work for a patient. And so we're sort of validating what we saw in small studies on a larger clinical trial. I say larger, but it's not that large. It's going to include about just 134 or so patients. But we feel like if the results are consistent with what we've seen in smaller studies, and this trial's open for patients all across the United States, that we'll be able to show that the PET scan is going to be a useful tool to help us understand what treatments are working. So individuals who decide to participate in the feature trial, they can be on whatever treatment that their doctor thinks is a good one for them. There's a few criteria, but for the most part, it's open to patients receiving anti-estrogen or endocrine therapy, and it's open to patients receiving chemotherapy as well, because we want to show that the PET scan will be helpful in all of those different treatment contexts. And then the last thing I'll say is just that the other part is that some of the scans that we do, like FDG PETs, they're pretty expensive. And a lot of times insurance companies haven't had enough data to be able to support covering the cost. And it's really painful for patients and for doctors when you have to get on the phone and try to convince or to cajole to get coverage for exams that you think are going to really help the patient. And so the other piece to the feature trial is that we're hopeful that by doing this in a really controlled way in a clinical trial, that could provide the level of evidence that is needed to allow this to become kind of a standard of care test, so that it could be ordered and it could be paid for and covered more frequently, so that patients would have access. Because right now, access can be a little bit spotty, and it depends where you are, what your plan is, what part of the country you're in. And we'd really like to make these types of tests that Dr. Jacene, these nuclear medicine tests, we really want to bring those and make it available to every patient who needs it. And so this is kind of the pathway that we hope will allow that to be, if we're successful with the study, if the study does what we think it does, and that maybe that this could be a new standard so that patients would have access regardless of whether they were on the trial or not.
Oh, incredible. You're like checking all the boxes. I am so excited to hear about this future trial. And, survivingbreastcancer.org was not involved in, being a patient advocacy group or anything in terms of like your clinical design and any of that, but just hearing all this thought that you put into it, just, I know is like music to our ears, to our listeners' ears, that you're really, putting the patient first and thinking about all of the, not just access, but then the financial components to get the access for this type of test, and really being able to make a case for it. So thank you. I don't know, breath of fresh air. Thank you.
No, we're super, again, and it's just a privilege to be able to talk about it to the community that we're really trying to help. And we appreciate this as well. But I will be quiet because I want Dr. Jacene to talk about her other studies as well, which are, again, a little different, but really important and super exciting. So
yes, please. Go right ahead.
Yeah, sure. So thanks, Jen. The second trial is called the DIRECT trial. And I think so far we've done a lot of talking about how you use these imaging tests to look for a response, whether the cancer is doing well with the treatment or not doing well. But nuclear medicine often has the capability of showing changes earlier than some other tests like the CT scan or those structural tests. So one of our goals in the DIRECT trial is if can we see very early so I should take a few steps back, but the DIRECT trial is also a different setting from the metastatic setting, is really for earlier stage disease when a patient is planning to go on to have surgery. And we know that after they've have sometimes neoadjuvant chemotherapy or therapy before surgery, that getting that complete response at the time of surgery, it provides really information about how the patient will do in the long term. So DIRECT is really looking at a very early time point after starting that new therapy, is whether the PET scan can predict actually what will happen at the surgery to then help guide the therapy. And so the idea is that if the PET scan shows a tumor kind of decreasing their glucose activity, that would be a good sign and that they should stay on the same therapy. But if the tumor is not decreasing its glucose, that maybe there needs to be additional therapy that's added before the patient goes to therapy. So it's called a biomarker. It's an imaging biomarker. And can we use that to help really, I think, not personalize, but really optimize the therapy. Optimize the therapy for an individual patient. And this is, I think, becoming increasingly important as oncology moves forwards and they keep finding new drugs, some which have toxicities that we may be able to spare patients if it looks like the tumor is responding or not responding to therapy. So that's kind of a lot in a little bit of a nutshell.
I wish I knew about this when I was going through treatment. I had neoadjuvant chemotherapy. And, on one hand, it allowed me time to really contemplate the surgery decisions I wanted to make. It wasn't like, you have breast cancer, next week we're getting you in for surgery. Here are your options. I really had time to kind of think holistically and personally about what would be best for me in terms of breast reconstruction and whatnot. But it would have been so nice to know I was on a variety of chemotherapies and immunotherapies and all of these things. Like, is it working? Is it not working? And I remember waking up from surgery thinking, this is like the best day of my life because this is the day they took the cancer out. Like, I framed it in this like really positive light where like, I know I'm going to be healthier after this because they're removing this cancer. And to find out that while I did have clear margins, I did not have a clear, complete pathological response to all the treatment that I was on. And so we went back on like some more drugs and other things. But like, it's one of those things where like, okay, I'm in it for the long haul. I will do whatever I need to do. But how great would it have been to know and be able to predict how well I'm responding, because everyone is different, right? Like why do some people respond and others not? And so the more data and information that we can have about our cells, our cancer, the genetics behind it, the biomarkers, like how amazing. And that's just in the last 5 years. So how quickly I think sometimes the science is progressing and the research is progressing, because I talk to friends who are newly diagnosed and I'm like, oh my God, things have changed completely from when I was diagnosed 5 years ago. So that's an exciting study too. We can't wait to share that with our listeners.
Great. Yeah, we're really excited about it. We're really excited to be able to, I think we've been talking about it for so long that it's really nice to see come to fruition and really start having patients enroll on the study and see where that will lead.
Amazing.
And this is so important for all the reasons that you both mentioned, but Heather's this direct study with Dr. Connolly, and she are leading. I'm not involved. I'm a big fan, but haven't been involved. But this is really important. It's really directed towards patients with HER2 positive breast cancer. And that's one place where our treatments have really accelerated and improved so much that there's a lot of talk. Sometimes they talk about de-escalation, but we kind of prefer the term, I think patients and advocates prefer the term optimization and personalization. So when your tool chest has a lot of different options, you want to try to choose what's going to be the most effective, but the least toxic. And I think that Dr. Jacene's study is going to be a huge success for us to be able to really do that and to have a lot more confidence in something that's easy to test, that could really help direct and help patients and their doctors make more informed decisions. And so, again, these are just, they're really, I think, important opportunities, and just delighted to see the direct study get started and be activated. And so I think it's also going to be a game changer for lots of patients. So we're excited.
Yeah, so much enthusiasm. My last question that is burning right now, I think, Dr. Jacene, you were talking a little bit about nuclear medicine as either like diagnostic or also therapeutic. Can you touch upon like what the therapeutic side of nuclear medicine is?
Sure. That's a great question. So I guess you could start off by thinking about it in the same way as the diagnostic. All the nuclear medicine agents, they have the radioactivity, but they also have a molecule or a drug that's very specific for a target. So for example, we talked about FES, which was looking for the estrogen receptor. So our diagnostic imaging test, and I'm using estrogen receptors as an example, not that this is in development, but you're using the estrogen receptor, the FES, as an imaging agent. And as we talked about, that imaging can tell us whether there's an estrogen receptor on a particular tumor or not, whether it's active. So with therapeutic nuclear medicine, you actually can change the type of radiation that is attached to the drug or to the molecule. And that radiation is a little bit stronger radiation. It deposits more energy. So the drug can bring the radiation close to the target and then deposit that radiation there and hopefully kill some of the cancer cells. In a way, it's I guess biologically, the radiation effects are very similar to what happens with the external beam radiation, but the molecule itself is really a very specific. It's a way of giving targeted radiation as opposed to having to just go through a lot of normal tissue in order to get there. I think another benefit is sometimes if somebody has multiple tumors, because you give the radioactive the nuclear medicine therapeutic agents through the vein, you can also target multiple tumors with a single dose of the radioactive radiopharmaceutical therapy compared to radiation therapy, which is typically a couple tumors or they have to do in multiple fields.
And that's currently in practice where someone could have nuclear medicine therapy.
So not for breast cancer right now. But probably the two biggest tumors that we use it for right now are there's a type of a neuroendocrine tumor in the gastrointestinal tract, and also prostate cancer. Right now is a big one where it's being used, but there's been a lot of nuclear medicine has been doing this type of therapy for a long time. I guess I should also say iodine therapy for thyroid cancer has been around since the 1950s. And so now there's a couple new agents that have come to the market, and a lot of new targets are being studied with this approach. So I'm very excited about that. And the imaging piece, I should say, is very important because that really can help guide, when the target is present in order to give the nuclear medicine therapy.
Absolutely. So you're really laying the groundwork with these clinical trials to identify the target and making sure that the therapeutics are working and then progressing. So thanks for breaking that down. I know I always joke where I'm like, oh, I'll send some questions in advance before our webinars or our podcast. And I always go off script because the conversations are so rich. And I love that we have you guys as experts to really help us understand what I call happens behind the curtain, right? We're the patient and I just show up, on the date and the time that my doctor tells me to, and I trust the process. But at the same time too, to really understand and have an appreciation for the amazing research and science and clinical trials and collaboration across the whole medical profession, whether it's, radiation, imaging, oncology, et cetera, that we're all making informed decisions collectively, and that there's a lot of people rooting for us as breast cancer patients. So thank you both for taking the time tonight to be on Breast Cancer Conversation, sharing your wisdom. And, I almost want to leave with one more question, but I know I want to be cognizant of everyone's time. But is there anything that we haven't discussed that you do want to share with our listeners that we haven't covered upon, or maybe I would say check in for next time that we can continue the conversation on if we haven't touched upon it?
I think I wanted to just add one thing. A lot of times I think nuclear medicine, I'm so glad we're doing this and you're doing this series because it does fall behind the scenes. And sometimes people hear the word nuclear and it becomes something that's very scary, or they get the card and they're like, what am I in for? But there are so many different nuclear medicine tests, and some are diagnostic and some are therapy. They're not all the same. So it's really, if you don't understand or you're not sure what the test is and it's nuclear medicine and you're worried, to reach out to your physician, and they can reach out to their nuclear medicine colleague to really help kind of ease and, answer any questions or ease any fears, because I think that's a really important thing that we're there for patients to help them understand why they're getting the test. And the word nuclear, I think, sometimes scares people, but it's not. It doesn't have to be, and that's part of, I think, our job is to help with those understanding too.
I appreciate that 100%. Dr. Specht, anything on your end to leave our listeners with?
I think two things. Again, I would always just like to thank your community and to your organization for allowing us the opportunity to talk about our work. And I always like to thank all of our patients and all of our supporters. And I agree with Dr. Jacene. This is just so cool because I think sometimes as a medical oncologist, I get the privilege of seeing the patients for their visits. But what they don't realize is how many people like Dr. Jacene, the pathologists, the people that are doing the genomic assays, how many people are on their team that unfortunately they often never actually get to meet. So they can love me or hate me, but I always like to, I think this is wonderful to be able to embrace and highlight the work that goes on behind the scenes, because you only get to see part of your team, and there's so many people who are working to try to make things better for our patients. And so it's really fun to be able to see more behind the curtain. So I would encourage you and love to have you bring pathologists on and others as well to really highlight all that they're doing, because it does take a team.
100%. I love that. Well, such a great conversation. You used the word fun. I hope you had fun on today's podcast. There's a lot of smiles going on, which I appreciate. We'll link to all of your clinical trials and everything that we touched upon in the show notes below, maybe even write a blog about it so we can promote it with our community members. And I appreciate you guys taking the time to be with us. So thank you. And thank you, everyone, for listening to our show. I would like to acknowledge that all of the information on our podcast are from personal experiences and are not a substitute for professional medical advice. You should always contact your medical care team. Our podcasts are made possible because of donations from listeners like you, so please feel free to make a contribution through survivingbreastcancer.org/donate. And there are so many ways to get involved with our nonprofit and our organization, not just through listening to the podcast, but through all of our virtual programming. So you can check out all of our lineups by hopping over to survivingbreastcancer.org/events. And as always, all of our programs, services, and resources are absolutely free. Thanks again and keep on thriving.